recording and say good morning to everybody, and thank you very much for Dr. Rich Goncalves, who has agreed to do a presentation for us today on a meta-review, which is basically a review of reviews on antidepressants in children and adolescents that was published very recently in Frontiers in Psychiatry. We thought this is a really useful paper to discuss because it has such broad applicability to think about the broad range of medications that we may use in child and adolescent settings. So Richard, thank you for doing the presentation, and thank you for letting us record it in case somebody else might want to watch it afterwards. I should say the paper is open access, so anybody anywhere can go to the internet and click on it and download it. So I think that's another reason why we thought it's a good one to choose. So with that, Richard, I'll hand over to you.
Great, thanks, Prof de Vries. Good morning, everyone. For those of you that I haven't met, as we said, I'm Rich Goncalves. I'm one of the Psychiatry Registrars at UCT. I'm currently stationed at DCAP. So I'll be doing the presentation today and reviewing this meta review article. I think the link was sent out, but just in case you haven't seen it, this is what it looks like. The title is Antidepressants in Children and Adolescents, a meta-review of efficacy, tolerability, and suicidality in acute treatment. It has 4 authors. They're mostly based in the UK at Oxford. It's appeared in the Frontiers in Psychiatry journal. And as we mentioned, it was published on the 2nd of September, so not even 3 weeks ago at the moment. So why was this article chosen? As we said, it's very recent, so up to date. It's important to remain current when we are using medications. It's clinically relevant. We use antidepressants daily with our patients, so it's important to know what is the evidence supporting our clinical decisions. And then it is, obviously, as a meta-review goes, it's a very broad overview of all the medications, the antidepressants, across a range of different mental disorders. So we'll be going into that a bit more. It could be considered slightly controversial in that some of the conclusions that they come to differ slightly from, or actually sometimes markedly, from what antidepressants are licensed for, or else for the guidelines that we have for some of the antidepressants use. So I'll be talking about that later. And then just for my own learning, it was important for me to see that children and adolescents are not just little adults. So if someone is depressed, you can't just use the same antidepressant and half the dose in a child or adolescent. So by way of introduction, we all know that there are many classes of antidepressants. So this includes SSRIs, SNRIs, NASs, tricyclics, and monoamine oxidase inhibitors. And these were all included in the study. And we obviously know that antidepressants can be used to treat a variety of mental disorders in children and adolescents, as well as in adults. But what's important to note is that the antidepressants can be licensed differently in different places. So for example, when you consider major depressive disorder in the UK, only fluoxetine is licensed for use, whereas in the US, fluoxetine and escitalopram are licensed for use. And if you consider OCD, in the UK, fluvoxamine and sertraline are licensed, whereas in the US, fluvoxamine, sertraline, as well as fluoxetine and clomipramine are all licensed. It's also an important topic because the prevalence of use in children and adolescents is increasing. So from 2005 to 2012, they've noted an increase in the USA, so particularly in the child and adolescent population, that the prevalence has increased from 1.3% to 1.6%. In the UK, from 0.7% to 1.1%. And in Denmark, it's nearly doubled from 0.6% to 1%. There are still some camps that hold that the use of antidepressants in children and adolescents is itself controversial. And this mostly comes from them questioning the efficacy and tolerability in young people. And probably the main piece of evidence that they use for that is that they hold that there's quite a high placebo response rate in children taking antidepressants. So this review in the introduction mentioned a study that placed the placebo response rate for antidepressants to be anywhere from 22% all the way up to 62%. So it is quite dramatic, and you can understand then why some people are questioning that if you could give a child, for example, a sugar tablet, and it would produce essentially the same results as giving a medication, why run the risk of the side effects and the adverse events of using a medication? And then just lastly, we're all familiar with the black box warning issued by the FDA in 2004 regarding increased suicidal behavior in children and adolescents using SSRIs. They do add a caveat that since then there have been further studies that have questioned the methodological rigor of that study, that analysis, but we all acknowledge it as kind of a landmark event in how we consider using SSRIs. Okay, then moving on to the method. So as Prof de Vries mentioned, I had to refresh my mind about what a meta-review is. And it's essentially exactly that. It's a systematic review of systematic reviews. So very meta. And it's essentially, it uses statistics to try and pool data from and summarize the results of a lot of different studies. And as you can see from the picture there of the pyramid, the evidence, hierarchy of evidence, the systematic review is kind of at the top there. And I think if you consider a systematic review of a systematic review, you might even be dealing with the apex of that pyramid. So what these authors did is they conducted a meta-review of the literature in children and adolescents, so 18 years and under, using antidepressants across a variety of disorders. So just further down on the page, you'll see the disorders that they used, that they explored. So ADHD, anxiety disorder, autism spectrum disorder, enuresis, major depressive disorder, obsessive compulsive disorder, and post-traumatic stress disorder. This PRISMA approach that I have mentioned on the slide, that is just a fancy protocol that they use when doing a meta-review. It stands for, it's an acronym for Preferred Reporting Items for Systematic Reviews and Meta-Analysis approach. So it's a way of conducting essentially a meta-review and some checklists and things. Very importantly, there were some exclusions in the criteria when they were looking at studies. And this includes that they didn't include people with comorbid physical health conditions or psychiatric disorders, including substance use disorders. If someone was on any other therapy, they weren't included, and they also excluded treatment-resistant depression. So essentially they looked at the database from inception, a few different databases, from inception to the 31st of October 2019, and they looked for systematic reviews and meta-analyses of double-blind randomized control trials. And they were essentially looking for any oral antidepressants treating children and adolescents under 18 years old with any of those conditions mentioned there. So what they did, in the drawing here, they ended up with 1,600. They removed duplicates and it got threshed down a bit. They then excluded more and essentially ended up with 147, which they then, for various reasons, also excluded articles. And the end result is they ended up with these 11 kind of systematic reviews that were then analyzed for this meta-review. Then I've mentioned that AMSTAR2 was a method that they used to assess the quality of reviews. And that is, with the acronym at the top there, it's a measurements tool to assess systematic reviews. And so it's just important to know, it's a tool that allows you to see at a glance how strong the evidence is from those systematic reviews. So you can see that it actually ranges from high in the one study to kind of critically low in two of the other studies. So it's important to know the data that you're putting in, how useful it is when you're going to have a result coming out. So they essentially searched all the antidepressants, and what they were doing, they were measuring outcomes in terms of efficacy, tolerability, and suicidality. And they were trying to pool all this data together. So efficacy was measured as the response to treatment. And this was either as a mean overall change in symptoms or else as a dichotomous yes-no outcome. Tolerability was measured as a proportion of patients discontinuing use of the medication due to adverse events. And suicidality was measured as suicidal ideation, behavior, including suicide attempts, and completed suicide. I'm going to discuss the results, but as it is a meta-review, it's quite hard to condense all of the facts because there are a lot of antidepressants, there are a lot of conditions. So I know some of the slides will be a bit busy, but kind of bear with me. I will summarize it at the end, and I'll also give just a few take-home points that are useful. So I'm going to go through the results now, just by disorder, and then at the end I'll give a summary of the most important points that they highlighted. So starting with major depressive disorder, they found one study, one meta-analysis that looked at 34 randomized control trials that investigated 14 antidepressants versus a placebo. So in terms of efficacy, of all the included antidepressants, and I've put them there just for completeness so you can see that they did compare a good range, but of all those antidepressants, only fluoxetine was found to be more effective than placebo in the improvement of depressive symptoms. And I think this is probably one of the main findings from the study that really stood out for me. When it came to tolerability, imipramine, venlafaxine, and duloxetine were significantly less well tolerated than the placebo. And then also importantly for suicidality, venlafaxine was associated with a significantly increased risk of suicidal behavior or ideation as compared to the placebo. And in anxiety disorders, there was also one meta-analysis, and it compared the use of SSRIs, SNRIs, and tricyclics as compared to placebo, and they treated a variety of anxiety disorders there. They found with the efficacy that fluvoxamine actually had the superior response to placebo, and it had an improvement in symptom severity measured. Interestingly, they found that sertraline, paroxetine, and fluoxetine were more efficacious than placebo, but only according to one and not both outcome measures. Wasn't exactly sure what they meant by that, but it seemed to imply, because the two measures were either is it better than placebo, and then secondly, does it improve symptom severity? So this is saying that those three were better than placebo, but then perhaps in some way they weren't statistically significantly improving the severity of the symptoms. Regarding tolerability, there were no significant differences between any active treatment and placebo. And then in suicidality, treatment emergent suicidality was greater in paroxetine than sertraline and duloxetine. Obsessive compulsive disorder, in terms of efficacy, fluoxetine and sertraline were both significantly more efficacious in terms of the clinical global impressions improvement score. And then all treatments except fluvoxamine reduced the total symptom severity on the Children's Yale-Brown Obsessive Compulsive Scale, with clomipramine the most efficacious. There were no tolerability data, and there were no cases of completed suicide. ADHD efficacy, there were actually two studies two systematic reviews that they came up with. So the first one looked at bupropion. It was the only antidepressant in that meta-analysis. And they found that it was significantly more efficacious compared to placebo on the severity of ADHD symptoms when rated by clinicians, although the teacher ratings weren't found to be significant. And then in the second review, they found that desipramine was significantly more efficacious than placebo in treating ADHD symptoms as rated by teachers. When it came to tolerability, there were no significant differences between bupropion and placebo, and desipramine also reported no serious adverse events. There were no data on suicidality that were reported. Autism spectrum disorder, in terms of efficacy, these are now medicines that we're not particularly familiar with. I think there were two studies, firstly. In the first one, they looked at this tianeptine, which is a kind of tricyclic, but it's a bit novel. It's got something different about it. It's not quite a usual tricyclic. They found that there was an improvement of inadequate eye contact and inappropriate speech when rated by the parents and teachers on the aberrant behavior checklist, but these results weren't supported by the clinicians, didn't find that. And regarding clomipramine, it was found to be more effective than placebo in reducing abnormal behaviors as rated by the autism relevant subscale of the child psychiatric response scale. And then in the second study, they found no significant differences between citalopram and placebo or fluoxetine and placebo in any of the rating scales. And then just the tolerability, tianeptine increased drowsiness and decreased activity. And then citalopram, they were actually very vague. They just said less well tolerated than placebo. And then suicidality, there were no significant differences between fluoxetine and the control groups on the suicide subscale of the overt aggression scale. When it came to post-traumatic stress disorder, there was one randomized control trial on the use of sertraline in the treatment of PTSD. They concluded that there was no difference between sertraline and placebo using the primary outcome measure, which was a UCLA PTSD index. And then tolerability, they found that there was at least one adverse event in 76% of patients using sertraline, and also 76% of those using placebo. So roughly the same. Suicidality, there was an increase in suicidality from baseline of about 11% in sertraline and about 8% in placebo, and no cases of completed suicide. And this is the last study. So in Euresis, there was also only one individual randomized control trial, and imipramine did not significantly increase the maximum functional bladder capacity, and there were no significant differences between the wetness and dryness scores between imipramine and the placebo. And no data was available on the tolerability or suicidality. So this is the worst slide. It's got the most information, but it's just a recap to kind of reiterate some of the core findings there. So we can just go through it together. So in treating major depressive disorder, they found that only fluoxetine was more efficacious than placebo. So that's a massive point. Then in terms of anxiety disorders, they found that fluvoxamine and paroxetine were significantly better in decreasing severity of the symptoms. In OCD, they found fluoxetine and sertraline were efficacious. And then in ADHD, they found bupropion and desipramine improved the clinician and teacher-rated symptoms. In ASD, clomipramine and tianeptine were superior on some of the core symptoms. And then they just confirmed that there was no antidepressant that was more efficacious for either PTSD or enuresis. In tolerability, in major depressive disorder, they found that imipramine, venlafaxine, and duloxetine were less well tolerated, and that there were no differences for any of the antidepressants in the treatment of anxiety disorders, ADHD, PTSD. And then just as we mentioned, the tianeptine and citalopram were less well tolerated in children and adolescents with ASD. Last point here, so suicidality, very importantly, in major depressive disorder, they found it was increased in venlafaxine, and then they found that in anxiety disorders, paroxetine also had a significantly increased suicidality risk. And then finally, sertraline in anxiety disorders was associated with a reduced risk. So what I've done now is I wanted to try and illustrate that some of their findings do fit with current licensing of antidepressants, and some of them fit with current guidelines, and then some of them kind of diverge from what the accepted licensing or guidelines are. So what I've done is I've taken this table from the Acute chapter on psychotropic medication, and I've put it there, and what I'm going to do now is go through each one of them. And the green circles are the ones that this meta-review has kind of agreed with and added evidence for. And then the red circles are the ones that it kind of is challenging and saying that this actually has no evidence or this shouldn't be happening. So just starting at the top, we're going through the green ones now. They did agree that fluoxetine should be licensed for major depression. And it's also part of the NICE guidelines that you should use fluoxetine for moderate to severe depression. So they completely agree with that. They also agree that fluoxetine and sertraline should be approved for OCD use. And they also say that there are no antidepressants that should be treating specifically ADHD, PTSD, or core symptoms of autism spectrum disorder. However, there were then the ways in which they diverged. This is, I guess, where it gets interesting. So firstly, they said that fluvoxamine actually does work well for generalized anxiety. And it's not currently licensed in the UK, the US, or France. So they're saying that the evidence supports that it should be, actually. Then the biggest casualty is probably escitalopram. So they kind of outright say that shouldn't be licensed for major depression as it is in the US, because there was no evidence in their review and that it works. And then they also were talking about the license for fluvoxamine and clomipramine for OCD. They didn't find that it significantly improved symptoms, so they're saying that those shouldn't be licensed. When it comes to guidelines, they were just saying that essentially that, when it came to anxiety disorder, that they would actually recommend that fluvoxamine, I mean, it is here, but that fluvoxamine gets used ahead of fluoxetine there, because it was found to be more significant for that. And then they also just said that in the NICE guidelines, it does have a whole flow chart of what you do for enuresis, but at the end of all of those, the NICE guidelines then say that if none of that works, then you should try using imipramine. And this review is essentially saying that even at that point, you shouldn't use imipramine because from their review, it doesn't have any effect. So then just the discussion. Firstly, they mentioned a bit about this neuroscience-based nomenclature initiative, which is very interesting. So this is essentially a movement that is trying to change the way in which we classify medications and the way in which the language that we use when talking about medicines. So they would prefer us to name medications by their pharmacology and their neurobiological method of action. So in this example, antidepressants would not be called, fluoxetine wouldn't be called an antidepressant, it would be called a reuptake inhibitor of serotonin. And I think they do kind of have a point, because the whole idea of the study is that these antidepressants are being used for a variety of different disorders, and it doesn't really add any value calling them an antidepressant. So the precision that it offers of being able to talk about something as a reuptake inhibitor of serotonin may in fact add some value. And if you are interested, I've listed the website address there for the NBN, and it's a really nice interactive website, well put together, makes a lot of sense. And they also have a nice app that I downloaded that kind of, it groups the medications together, and you can compare quite nicely different medications. That's a useful thing. Then just in terms of going through strengths and limitations, the main strength, I guess, is just how robust, like all the hoops that you have to jump through for a meta review. So the fact that all the studies that they're drawing from were double-blind, randomized control trials, which are kind of the gold standard, and they've used all these protocols for how to extract that data and quite kind of strict guidelines. So you can show what they have done and where the information came from. However, I did find that there were some limitations. So just to mention the variable AmStar2 quality of the systematic reviews. So just to go through it again, they did have one high quality, but then a couple were moderate, and then there were 2 critically low and 1 low. So for example, if we're talking about anxiety disorders, I don't know if we should be making big decisions based on this one review that scored critically low on an AmStar2. So just kind of food for thought. And then the exclusion criteria. I mean, I know that research likes to be clean and have very set parameters, but the fact that they excluded anyone that has any other psychiatric condition or any other physical condition or using another medication or treatment-resistant depression, it just means that our patients, unfortunately, don't come to us like that. So we've got to kind of bear in mind that this is the very specific group of people that they are showing the results for, and it may not translate necessarily into the patient that's sitting in front of us. And likewise, I found that the cutoff for their tolerability, the fact that it was quite at the end of the line, saying that it was only intolerable if you stop the treatment, that's quite a little bit vague maybe. So it's not offering us any information on side effects, or this was almost intolerable, they almost stopped taking the medication, but they pushed through, that kind of thinking. So it kind of leads me on to the next point, which is that when you're dealing with the results from a meta-review, you have to have a considered response to how to use this information, because it's kind of a more broad overview, and it gives you information for like a population. It doesn't give you necessarily information for this person sitting in front of you, thinking, if I start this antidepressant, is it going to have this side effect? Is it not going to have that side effect? So the meta nature of it is probably that this information is useful, but it must kind of be, I guess, deep in your subconscious and helping make decisions at a broader level, not at a case-by-case basis. So this is my last slide. And as I said, I would distill it into a few very practical points that we can maybe put into our inception, into our brains at the bottom. So the first one is that they found that only fluoxetine was more efficacious than placebo in the treatment of major depressive disorder. That is a big one. But likewise, we can also stand on the fact that fluoxetine does work. So that's good. And then when dealing with OCD, fluoxetine and sertraline were more efficacious in the treatment. They confirmed that no antidepressant was more efficacious for PTSD or for enuresis. And then just to know that they went through all of the antidepressants that we have available for use here in South Africa, and they all essentially had similar tolerability and suicidality risk besides venlafaxine, and that was quite important. So venlafaxine, they found in major depressive disorder, had an increased risk of suicidality. And that's it. Thanks very much. Any questions?
Well, so making going to be about those two little guys, or guy and gal in front of us?
Yeah, so this is Sienna on the left and Oliver on the right. They were born just before this article came out, about a week before. So they're also fresh off the press.
Wonderful. And that's a lovely illustration for us, I think, of the mindfulness, exactly as you said, of thinking what is the average basis of evidence, and then how do we translate that into the individual in front of us. So quite a different story. Lovely. I'm going to suggest, Rich, you stop sharing, and then I will stop the recording and we'll open it up to conversation. So let me just pause and stop that.